Good morning, everyone.
Good morning.
Good morning. I'm just waiting for a few more seconds for a couple of others to join.
That's okay.
So we will make it start.
Thank you.
Good morning. Let's start up now. We waited for a couple of minutes. I think we've got a few learners which have joined. That is great. So let's kick off today's discussion. Now, I know that I've got Farida, which is primarily sent me the person-centered, approach document, which was something I mentioned that everybody should look at, attempting, and that would have been great because it would have covered our yesterday's session in terms of what we've discussed in a bit more detail. And that was to understand what are person-centered skills, what are the principles of person-centered care, and how do you relate that to your own personality. So, or in your case, when you work within the sector in a health and social care job or a job role, essentially, how do you look at essentially, relating it to yourself in terms of the 8 attributes that we talked about, independence, dignity, respect, and how do you come across and use these while providing care to the, clients or, in this case, patients and basically customers. Now, one of the things which some of you would have read in NHS is that NHS basically, ensured that they will follow a customer-oriented approach from November of 2022. That means all patients coming in to receive care, whether it's primary, secondary, any sort of care, would be basically given treatment as if they are coming in to receive, as a customer. They'll be treated as customers, and obviously the care being provided, will follow certain patterns and guidelines related to the 6 C's of care, the person-centered approach, which is the central philosophy as far as the NHS is concerned, in terms of National Health Service is concerned. So when we look at this in particular, I want to show a quick document which I mentioned yesterday should have been filled, and that would essentially help you recognize, I would say in particular, that whether do you have these skills, whether do you show these traits which are required when you work within the sector, and how would you use them and relate them to the concept of providing personalized care which is tailored to the individual's needs and requirements. And that is something that I had requested. So if I just share this now, I had requested that everyone should look at completing this document. And at that stage, this document will also be useful because it will help you meet the guidelines of task 1.1 in particular. Now, before I press record, I would also suggest if you're not asking any questions, just mute your microphone in the background. So in order to reduce any background noise. If I quickly go into looking into the recap of what we discussed yesterday through the presentation slide, we did cover only person-centered approach, the principles of person-centered approach, and how they are useful in providing integrated care or personalized care to patients. So I don't know how many of you have filled this up, but this document that you see on your screen is something which I would suggest you need to attempt today, because this will become a part of your assignment, and this will be very specifically related to you, because it will highlight your skill set in requirements to working within the health and social care sector. Now, if I now look at switching over to this slide, because today what we're going to do is complete learning outcome 1. And when we look at completing, so today what we're looking at is doing completing learning outcome 1. And if I switch over to the slides, what we're going to do is discuss the part 2 of the learning outcome. And this will primarily be focused on, covering some of the assessment criteria like 1.2, 1.3, 1M1, which is the merit criteria, and the distinction criteria. So we are looking at discussing today ways in which person-centered approach contributes to the continuity of care. So this is what we had discussed yesterday, which was related to, understanding what is person-centered care, by taking up an example that when you visit a surgery and you speak to a nurse or a doctor, how the advice is given, how the nurse looks at diagnosing your problem and then gives you appropriate information related to your condition, and then you are in control in terms of having had that choices, having had that information, then you are going to be looking at making an independent decision whether you will undertake that treatment, whether you will undergo that procedure, or whether you will be requiring medication, things like that. We talked about the definition of person-centered care, and obviously why this has become the agenda in NHS, because when the NHS Act was introduced in 2010, this has become the central core philosophy of providing care to patients, which is putting people first. And this concept of PCA, or person-centered approach, is factored on 8 values or principles that we discussed in a bit more detail yesterday, which was the principles like respect, dignity, individuality, choice. We looked at your rights essentially, but in this it's more or less reference to the human rights. That means you should know your rights in terms of what you can do, cannot do, and where you need to seek advice or seek help. And that is what covers in rights. So you have the right to get full information, you have the right to your privacy, you have the right to your individuality, you have the right to, to have your beliefs, your values, and then those have to be taken into account while care is being delivered to the patient. We looked at independence. So all the information sometimes need to be provided to you, and then you are under no pressure, or you are not being persuaded to take a decision. Your decision-making process is totally independent. And then when we look at people who work in partnership within the health and social care sector and carry out roles or are responsible for delivering, let's say, different types of services within this particular role, they also have to adhere to the central code of practice, which has been set by the provider. In this case, if we talk about NHS, but if we look at GP surgeries, they follow the same guidance and the same rules and regulations which are laid out, for all departments within the Department of Health. And that they tend to be, they also are needing or requiring to essentially have the same guidelines, principles, policies, and procedures to be able to deliver that level of, support. Now, in the second assessment criteria, we are looking at understanding how person-centered care actually looks at, providing continuity when you are suffering and you are essentially requiring continuous care, from your carer or say from the medical staff. Now, there are different definitions of how we look at this as an aspect, but generally speaking, Department of Health, which is DOH, basically defines that person-centered practice is put at the center of everything that is done within the National Health Service. Now, in this case, there are lots of other definitions by Baker Rajan, which basically says that when we talk about person-centered approach, it is basically services being delivered in a coordinated manner by different practitioners which are involved in providing this care. So when I use the word practitioner, what I mean by the word practitioner is different sets of people which essentially, are dealing and providing care through which these services of care are being delivered to the patient. So practitioners could include healthcare professionals, healthcare assistant, it could include nurses, doctors, GPs, consultant, therapists, occupational therapists, people who are in the support role. They will all be considered as a part and parcel of being called as practitioners. And they are responsible for ensuring that the service being provided, which is essentially care, is done in a way wherein the person is actively engaged and the person receiving the care is able to then get the full benefit of the care plan or, care being provided. When we look at care being provided and there are different practitioners involved, generally you would see that there is a care plan which is created. And that care plan does become, a bit of a Bible or a document which essentially everybody follows through in terms of providing, or delivering the services they are required to do for ensuring that the patient receives it. So, for example, one of the key things that we look at is assuming you're undergoing an operation. Now, when you are undergoing an operation, there are lots of different types of teams which are working, and those teams will be responsible for providing basic care, primary care, domiciliary care, if required, psychological support, and also consultation with your family members in order to ensure that you are fully informed in terms of what the procedure is, what the operation will involve, what are the risks, what could be the outcomes, projected outcomes, and how will the patient benefit from it. Now, when we talk about all this, we are looking at a care plan being created. And that care plan essentially is like a macro document, which will document everything in terms of all these sets of information which will be required to be provided to the patient families, maybe the doctors, and people who are involved in essentially delivering of that care. And they would essentially put together a bit of a plan. And that plan, if I say, would be called a care plan. Now, when we talk about care plans, there could be lots of different types of care plans that we look at, but generally an example of a person-centered care plan would be incorporating these basic fundamental principles, which include things like why we are looking at making sure that persons' needs, demands, basic the rights of dignity, respect, privacy, independence are taken care of. And these are the bits that we will be looking at, putting into that particular care plan for that particular person who's undergoing this operation. So when I look at a care plan, what I also want to do is, I don't know how many of you have actually seen a care plan, but it will be important to maybe see a template, because a care plan will have elements like personal information about the patient. It'll have its medical history. It'll have, what kind of support has been provided in the past, whether it's, mental health support, whether it's social support, what could be the risks that the patient is, going to face when they undergo some sort of an operation. What are the nutritional requirements of the patient, whether you're a vegetarian, vegan, you have allergies to certain type of food or food products, the interest in activities that the patient is interested in, and in terms of communication, what is the preferred language of communication with the patient, and do we need an interpreter? Is the person's first language of communication being English in the UK? All these things will be a part and parcel of when we look at a care plan. Now, a care plan essentially would be like a main guiding document which will allow all the practitioners who are involved, that means all the people who are involved in providing care to that individual, they will be using that document to basically look at what part of that role they will need to play, and they will be looking at adhering to that document when we talk about this care plan. So when we look at an example of a care plan, there could be lots of them, but a good template to look at would be from the CQC website, which is the Care Quality Commission website. And it provides templates which basically care homes, or, say, for example, any sort of a setup would essentially use or have when they talk about, putting a plan together for somebody who's undergoing, say, for example, a major operation or a major procedure in the hospital. And in those cases, a detailed planning document would be required to be created, which will take into account everything at some stage, which will be connected to the patient. And that will be, used as a document later by different sets of people to be able to look at, using it for the purposes of making sure that they are prescribing the right, say, diet or nutrition, they are prescribing the right set of medicines. All those things will have to be taken into account. Now, if I just briefly show you an example of a care plan, which I want to, because at the end of the day, you should be able to have a document and should have seen a document which basically talks about care planning, which is done normally for a patient which is undergoing, say, some sort of an operational procedure. Now, this is a draft template that I've downloaded from the CQC website. As you would see, as I mentioned earlier, the care plan, or this particular approach of person-centered care, which depends on creating a care plan for a patient, would have basic details like, personal details of the patient. It will also have, previous medical history, details in terms of support which has been provided, medication if you were on, if you have had any allergies, any particular conditions. All these are very carefully documented in this particular care plan. Now, this is a draft template, and this template keeps expanding depending on, what the patient is undergoing in terms of treatment. And this would then be useful because it will be developed into a personalized plan for the patient, which will be used by practitioners, nurses, healthcare assistants, doctors, consultants, GPs, people who will provide support even after the patient has left the hospital. And it will be used by maybe carers, it will be used by care providers, it will be used by family members, and they will use this document primarily to communicate and coordinate any sort of healthcare planning or any sort of planning which has to be done in order to ensure that the patient gets better and patient comes out of that particular condition. So this particular document is an important document because this looks at how person-centered care can be delivered, to a patient who's going to receive, say, for example, some sort of a treatment. Now, at some stage, taking you back, this template will be available on Moodle after the presentation and complete coverage of Learning Outcome 1, just for you to have a look at. Now, after we look at putting this plan in place, and the idea is to understand why is person-centered approach important. Now, person-centered approach is important is because you are not the only one who's going to give the entire treatment to the patient. You are not the only one who's going to be responsible for providing the entire treatment. Sometimes when you have smaller illnesses or problems like, say, fever, running nose, or cold and cough, then maybe the GP might be primarily looking at prescribing a medication or a plan to you, but at the end of the day, the prescription is handed over to a pharmacist. Before even you leave the GP surgery, you would generally have an appointment with a nurse. You might be looking at meeting somebody at the administration. Even in a small condition like that, when I say small, I mean a basic condition like cold and cough, children typically, when they see the GP, will still require them to basically go through a couple of things like their background, their previous medical history, any sort of medication, allergies. And as you would see, even a small or a basic condition like having cold and cough would still require the GPs to look at consulting everything about the patient from their patient record. And that would mean that before they prescribe any sort of medicine, they would look into basic details like allergies and previous medical history to ensure that the prescription or the medication being prescribed is something which is going to be useful and beneficial to the person. Now, here again, there's a coordinated approach, because after giving the prescription, the parents are involved in administrating it or making sure that the child or the children have the regular doses. The pharmacy is involved in preparing the prescription, which could be done, for the prescription which has been provided by the GP. The GP surgery essentially would be involved, and as you would see again, this becomes a coordinated approach. This is not that the GP issues a prescription and in isolation you are able to get all the treatment. No, there are a number of people which are involved in administration, documentation, preparation, and even administering, and then obviously giving the medication to ensure. And then towards the end, you look at measuring the results. So if your fever does not go away, cold and cough does not get better, then in those cases, you again visit the GP surgery. And then again, the medication might be changed, maybe more investigation would be done. And that is where you see the approach of, person-centered approach being put into play for the purposes of ensuring that personalized care is provided, which is important for the patient, or in this case, the child, to get better. Now, there are lots of examples, and one such example that we could look at for the purposes of discussion would be that if you see and assume that the scenario, if we look at as an example that I've put here, is that there's a person, Malcolm, who is 27 years old, and he has had an accident. Now, because he's had a fatal accident, he has had to undergo surgery for both his arms because he had suffered severe injuries, and he needs to be, he would be hospitalized for a period of 2 weeks or more before, the consultants and the doctors are happy with his recovery and his condition. And then after that, he would require daily care or, some sort of personalized care, which will be required to be provided to the patient for him to fully recover from that accident. Now, there are, after the basic operation has happened, things like, because both his arms are incapacitated and the person is recovering, he would need help from healthcare professionals, nurses, to be able to do daily chores or duties like fulfilling his needs in terms of, eating, drinking, bathing, and, other bits, because he cannot use his hands till the time he is fully recovered. And in those cases, you would generally see that he would require additional support and help, which is going to come from the periphery of the ecosystem of the National Health Service, which will involve healthcare workers, nurses visiting him at home, administering medicine, changes of maybe bandages or plaster, and looking at basic course which will be provided, which he would need help or getting help on from essentially the the healthcare assistant. And here, after we look at the discussion with the patient, the doctor, the consultant, the GP, and essentially, the person who has undergone this operation, what will happen is that they will put together a bit of a care plan. And that care plan would mean how many times the healthcare assistant would go per day or in a week, essentially to be able to, help out, and what days or times the nurses would visit, what kind of basic help he would need to pass his time, things like maybe access to a TV, a e-reader, and all those things are going to be put together in the plan. Now, why is it person-centered approach important? Because we are taking into account his we have to personalize the support which is being provided. We will take into account things like his independence, his culture, his belief, his values, his nutrition, his diet plan, and all those will be customized and tailored to suit the requirements of Malcolm, who is going to be receiving this particular plan. So in this context is what we look at, why person-centered approach actually becomes important. And if I have to summarize some of the points that I've mentioned here with the use of the example of Malcolm, then I would say that it would be useful to put this approach into play, because you would see that the patient would feel comfortable and confident in receiving the service. There will be emotional support and support which is provided by his friends, family, and the healthcare assistants and others who would essentially put this plan into action to ensure that everything which is being documented, everything which is as per requirement is given to the patient. And communication will also be a key which will allow the patient to receive information. And when he receives this information, he is able to take independent decisions in terms of this is suitable, that is suitable, I would like to eat this, or I would like that, or I would not like to undergo this particular thing. I could be able to manage my own, basic course. Those are the bits that you will allow the patient to then make a decision on. So in those cases, you would be essentially looking at the person-centered approach actually, becoming useful, because they are going to allow the patient and the practitioners to take into account the preferences of the individual and then put together a plan which is going to work for him, and he then is able to recover from that condition as soon as possible, and the recovery is projected as planned by the consultant and the medical team. So any questions on this discussion that we've had? Okay, next, let's go across to the next assessment criteria, which talks about, describing the role of safeguarding and protection in person-centered approach. Now, one of the key things that we look at primarily when we talk about the approach of, person-centered care, we look at talking about what is called safeguarding. So when we talk about safeguarding, what do you mean by safeguarding? Anybody, any ideas on what do you mean by safeguarding? Anybody in terms of?
Maybe any protection for yourself and your clients and the whole system that is working for the client.
Okay, so in this case, when we talk about, safeguarding, that is correct. So it is basically some sort of an action that you will take to promote the welfare and, give the confidence to the patient that every type of planning which is being done to provide the care is being done with basically keeping them in mind. So in this case, you're looking at, making sure that, essentially, making sure essentially that the person feels safe. They feel protected. They do not feel vulnerable. They do not feel that they are being abused. And, they also feel that they are also not being maltreated when it comes to their dignity and, their individuality. So in this case, safeguarding, is important because of this particular reason. Now, we will look at various things in terms of, why safeguarding is important and why it is related to person-centered practice. So just give me 1 second.
now I am a mainly, the administrator, HR. So I want to go for other, the next step to doing myself. Management.
So when we talk about this process of safeguarding, we will be looking at understanding a few acts and legislation which are important, which the government has actually put in place. And these have been put in place because of the fact that the patients or people who are receiving care in any sort of a setup, they feel that they are protected, they are not in the harm's way, and also they are getting the benefits of care which are irrespective of their culture, their background, their race, their religion, and there is no discrimination being wetted out primarily when we talk about treatments being provided. Now, safeguarding has a wide-ranging definition. Safeguarding could be considered in any context. It could be considered in the context when you're working for an employer, that the employer is responsible for providing you safe premises, which ensure that there's health and safety of the individual and the employees working within the organization. That could also be safeguarding. Implementation of policies like equality and diversity, discrimination policy, Disability Act, that you're not discouraging or, essentially, let's put it this way, disparaging against somebody who has a disability. And those examples that I'm giving would be also, related to safeguarding in general. But when we talk about safeguarding in general, in relation to health and social care, we are going to be discussing the basic 6 C's of care, which are what any healthcare provider is required to put into place. And these 6 C's that we are going to study are going to be responsible at a later way we will study. They are going to be responsible because they are related very closely to the Health and Social Care Act of 2014, and also, the 6 basic principles of safeguarding that any such institution or any such organization involved in health and social care sector has to maintain. Now, when we talk about safeguarding, we generally would look at basic aspects of, discussing things which are related to individuals feeling confident, and they feeling that they are basically confident, and they are feeling basically they are protected in this case. And their basic rights are being respected while the care is being provided in a particular setup or say by a particular provider. And safeguarding in particular in the last few years has been aimed at looking at, ensuring that people are actually free from, say, let's say, domestic abuse. They are free from any sort of pressure which has been put onto them to do a task. Slavery, modern slavery, as we call about or talk about or hear in the news, sometimes is also a part and parcel of safeguarding. We are going to be looking at, when we talk about safeguarding, we look at human trafficking, we look at modern slavery, we look at domestic abuse and violence, we look at pressure against taking decisions on certain things which the individual doesn't want to do, but they are being pressured into taking or making that decision. You're looking at the mental health services or mental health capacity, of the patient to be able to make decisions, sharing of information under the Data Protection Act, and in terms broadly relating to, the Care Act of 2014, which is important, wherein anybody who's receiving care within a particular setup is able to, feel protected and is able to feel safe while receiving these services, is the main aim of safeguarding. Now, some of the bits which I've mentioned, why is safeguarding important and how it is ensured that, this is something which is present within a health and social care organization. So safeguarding is closely related to the Care Act of 2014. And when organizations implement, safeguarding procedures within an organization, they have to have basic things like a safeguarding policy, certain other policies which they have to implement and adhere to, things like data protection, discrimination, equality and diversity, a disability act. Those bits they have to ensure that they have implemented within a health and social care setup. The other thing which they have to look at is they also need to have what is called a safeguarding adult board. That means somebody who's designated as a safeguarding officer, and people can in confidence go and make a complaint to that particular person to say if they feel uncomfortable about certain aspects and they feel that they are being vulnerable to certain aspects of working or within the working environment or receiving treatment, then they should be able to freely be able to go and essentially speak to that particular person. Now, when we look at in this particular task, we have to look at discussing why safeguarding is important and how is it related to person-centered care. So here we need to be looking at discussing what are the 6 principles of safeguarding. Now, the 6 principles of safeguarding are empowerment, prevention, they are proportionality, protection, partnership, and accountability. Now, these are 6 principles which have been laid down by the Department of Health in 2011, and they are now embedded in the Health and Social Care Act of 2014. And these 6 principles for safeguarding apply to all healthcare settings, any set of a type of a setup, care home. When I say healthcare setting, I mean a setup which is like a care home, like a hospital, a surgery, a community center. All those things would typically apply when we talk about the healthcare setting. So here, these 6 principles include empowerment. That means people should feel empowered to be and encouraged. They should be encouraged to take decisions, and they should be able to give their own opinion in terms of making those decisions. We look at prevention. Prevention is better than cure, which is a very old saying. And this is what comes into a place when we look at the process of safeguarding, is that if we feel that these areas are going to be susceptible to, say, for example, harm, or if people would have that harm in those cases, then we would be looking at, making sure that as a risk assessment, as risk experience, that's correct. And we should be able to, detect those and then prevent them early enough to be able to prevent those mistakes from happening, lapses from happening, or medical negligence from happening. We look at proportionality, which is basically talking about ensuring that the procedures and the processes that we are applying are related to care and are proportionally applied in the case of a particular patient. Now, if the patient has cold and cough, you will need to apply, accordingly a care plan. If the person has had a serious accident and there are fatalities, you will need to apply proportionality in terms of ensuring that, okay, these incidents do not happen, and risk assessment is done in order to ensure that if there is something to happen, then proportional response is provided and it is immediate. Obviously, we look at things like protection, which is to ensure the whole aspect, and the core principle of safeguarding is to ensure that patients feel protected. They feel that they are not in the harm's way, they are not being mistreated, their dignity, respect, and they are not pressurized into taking any decisions or making any decisions which they don't want to do. Then we look at accountability. The organization or the healthcare setting in which safeguarding as a process or as a principles are applied stands accountable, because that is where the appointment of a safeguarding officer comes in. That is where the implementation of the safeguarding policy comes in, and the adherence to the guidelines of the Department of Health Act of 2011 needs to be fully implemented in the healthcare setting, wherein the organization and the management in the organization is accountable or held accountable to make sure that the implementation happens as per the laws and legislation laid out in this particular act. And that is where this particular task will be looking into relating it to the 6 C's, which is the care principles and the safeguarding principles, because it is closely related to the Care Act of 2014. Any questions on this? Is it clear? Is it understandable? And if you have any questions, feel free to ask me. Now, we'll You can ask me questions through the chat room as well. That's fine. And you can contribute in the discussions as you would want to do. And if you have any points, please make those while we go and discuss some of these assessment criteria. Now, the other bit that we will focus on is task 1.4, which talks about now nicely leading into what are the benefits of taking positive risks when we are assessing care plan or services being provided to individual customers. So here we are looking at understanding, ways of how objectives can be fulfilled, how monitoring and achievement of the objectives set in the care plan can be done. Sometimes you look at taking risks to provide a certain level of support to the customer. In this case, when I say customer, I mean patient, and that would be to give them better chances of speedier or quicker recovery from a particular condition, and also to provide support which might not be necessarily documented, in I would say essentially the care plan for that particular patient receiving a particular care. Now, when we talk about in general, positive risk, have you come across the term? What is positive risk? Has anybody come across the term which is positive risk? When do we say that we are looking at taking positive risks? So when we talk about, say, for example, let's take an example of technology, because we're doing our session through Zoom meetings. So let's take an example of technology. Now, one of the positive risks that I am taking right now is I'm delivering this session through Zoom, and I'm using Zoom software or Zoom meeting software to be able to deliver my session. Now, there's a bit of a risk associated with this, but it allows me to reach everyone in their homes. And some of you are attending, you're in different places in Manchester, but the technology is enabling me to actually deliver this session using Zoom meetings as a software to the doorstep or to your doorstep in your homes. Now, there is a bit of a positive risk, which basically means that if the internet is to go down, or if there's a bit of a disconnection, there will be a bit of a disruption in terms of the delivery of the lecture. Now, this is a positive risk which is associated with the use of Zoom meetings as a technology. So currently, I would say technology that I'm using could be posing a bit of a risk if the internet is to go down. And in some cases, if there is a bit of a disruption when we talk about, let's say, internet being temperamental, or the in this case the software being temperamental. So here the positive risk is about to identify any sort of potential benefits or harms which could come off when I'm using Zoom meeting as a software. So when we talk about positive risk, what we're essentially talking about is the desired outcomes which we need to basically say meet or come to. But in some cases, what we will do is, in order to reach those desired outcomes, we will encourage and support people to take a bit of risk, which will allow them to get better soon. And I'll give you an example here, which I hope you'll be able to relate to. For example, you had an accident. We looked at Malcolm as an example, and he's had a fatal car crash, and then because of which he's actually, maybe will need some sort of physiotherapeutic support to, start walking, or maybe getting rid of the wheelchair. Now, he attends, say, physiotherapy sessions every day, and the physiotherapist actually pushes him to stand, or, pushes him to go beyond a certain distance that they have set for that day as a target. Now, he might have set a target that, okay, today's target is to get up from the wheelchair. Now, what is the positive risk? He is encouraging the patient to take that risk to try and get up. Although in the care plan, it would have said that, the patient would require physiotherapy sessions for a period of 6 months. But within the 6 months, they would have further divided that sessions into, okay, getting rid of the wheelchair access, maybe 10 days. Now, what the physiotherapist is asking the patient to do is pushing some boundaries, motivating it, encouraging the patient by, motivating the patient to say, yes, you can do this. You try, you can get rid of this wheelchair, instead of, yes, tomorrow, you can do it today. All you have to do is make a bit more effort. So here, the physiotherapist is pushing the patient or encouraging the patient to take steps towards maybe early steps towards getting rid of the wheelchair. And this is where I would say the physiotherapist is taking a calculative and a positive risk to try and achieve a personal goal of what has been defined in the care plan for that patient. Is that understood? Yeah, is that understood? So what you see is the patient, patient being encouraged, patient being supported by the physiotherapist to try and get up, although the leg muscles are weak and things like that, but they are, the encouragement is being provided with exercises and support and motivation to try and get rid of the wheelchair sooner than what maybe has been projected in the care plan. And that is where you would see that this will basically mean that the physiotherapist is doing positive risk management, which is trying to, motivate the patient to and encourage the patient to say, okay, yes, you can do this, and these are the steps that you need to take to be able to do this. So positive risk is about building confidence with the patient, and it is about ensuring that required is explained on the basis of which the patient can make an informed decision, and that informed decision can help the patient recover or have the patient come across and get a speedier recovery than what has been planned or what has been essentially set in the plan for the patient. So here, when we talk about positive risk taking, we are looking at recognizing that risks are associated with many aspects of what we do in our day-to-day lives. So for example, one of the risks that we can look at when we talk about is, you're deciding you want to cross the road and it's a busy road and you want to cross the road. You're looking at, risks which are associated with men. If they do shaving every day, there is a risk associated with it that you could have a cut when you're trying to shave. Now, but that is a calculated or a positive risk that you're worth taking, because if you're careful and your attention you don't get dissuaded or diverted from what the activity that you're doing, you'll probably not get a cut, but that is a positive risk of shaving your beard. You could also have some sort of positive risks, which I can say, which could be associated with playing sports, like you play rugby, you play hockey, you play football. What could be the positive risk? That if you have an injury, that injury could be maybe a long-lasting injury. If you fracture your knee or fracture or break your muscle or strain your muscle or break your ankle, it could be a protracted injury that could mean that you'll have maybe a recovery in about 4 to 6 weeks or even 3 to 6 months. But that is a positive risk, and that does not mean that the person as a footballer or as a cricketer or as a rugby player, you would probably not play the sport or give up the sport. So it is about recognizing the risks which are associated when care is being provided. And what you're trying to do is, by creating that care plan, you're trying to avert risks which could essentially be, let's say, more fatal or could, exacerbate the injury or the recovery which the patient is trying to do. And that is what the benefits of positive risks would be. Now, some of the benefits include things like you're encouraging and providing support, and that would mean that you're allowing the patient to make decisions by giving him greater or her greater independence and autonomy. You're looking at providing information which will allow the person to learn and obviously gain from that experience. It will boost or bolster the self-esteem of the individual, and the individual in this case receiving the care would feel more in control of their lives, and they would be happy to make the choices which they want to in order to get well better or get well soon. And that would be the approach when we talk about positive risk taking in the context of person-centered care. Any questions on this? Okay, now if I go on to the merit and distinction criteria, the first merit criteria talks about, we need to talk about the 6 C's, of care. And these, as I mentioned to you earlier, are basically incorporated in the CARE Act of 2014. Now, what are the 6 C's? 6 C's essentially they are principles which we have to adhere to when, as a person working within this sector, we have to ensure that we are incorporating the 6 C's of care, which are now considered very important part of person-centered care. That means personalized care plan, which is provided for patients. And these 6 C's are bits which have to be embodied in a healthcare professional, assistant, a doctor, a GP, a nurse, somebody who's dealing with patients directly. What are these 6 C's? These 6 C's basically talk about care, compassion, competence, communication, encouragement, and commitment. Now, each of these are very clearly defined. When we talk about care, essentially, care represents that the person who's providing the care and support to the patient in this case is currently, basically, let's put it this way, fully aware of the requirements of the profession, which is the health and social care profession. They have the knowledge, they have the academic knowledge and the experience to work within this field, and they understand the basic requirements of providing care to patient. And that is what the C of care would stand for. They have, when I say they, I mean people who work within the sector have had a good experience of working, good enough experience of working, which they have had within the sector. And those experiences allow them to develop as an individual and provide care, care which is related to, the quality and the procedures which is laid down, or laid down by the provider in the area in which they work. The next C is compassion. How do you demonstrate compassion? Compassion is basically, anybody understands what do you mean by compassion? What is the definition of compassion? So compassion is basically you're showing some sort of sympathetic, let's say, concern towards an individual. If the individual has suffered, for example, with an accident, you are being compassionate in the way that you are able to relate to their situation, the misery or the trauma that they're going through. And in this case, what you're trying to do is basically give them or provide them support, both mentally, emotionally, and in some cases, physically as well, through the treatment which is being given across to the patient. So here you're looking at maybe acting intelligently kind, which means that you are showing empathy, patience, and understanding and consideration towards their condition. And that is what is expected of somebody who works within this sector. The next C talks about competence. Now, competence is the skills, basically the skills and the knowledge and experience that you need to have to be able to work within this sector. So when we talk about competence, it is academic competence, it is vocational competence, it is hard and soft skills. It is experience that you have racked up over the years of working within this sector, which has made you a better individual in terms of understanding how care or care planning and care, has to be provided, or support has to be provided to patients within this sector in any sort of healthcare setting. And this would be, if there are bits and pieces that you are lacking, then as an employer, the National Health Service or wherever you work, they will be putting training and development in place to ensure that you have that competence. That means you have that skill, you have had that training, and that training enables you to work more efficiently, more productively, more effectively within the role that you're performing within the health and social care sector. Communication, which is the next C. Communication is obviously quite important in this sector because, as you know, some of the areas when you start to work, numeracy and literacy are a key requirements in terms of ensuring that you're able to communicate, able to understand what the patient is saying. Things like being a bilingualist, if you're able to speak more than one language, is a positive or is considered an asset, because in some cases when patients are not able to converse with you in their first language, then interpreters or bilinguists are used, and essentially communication becomes the key, wherein you need to be able to comprehend, discuss, and deal with different situations. And that is all done using how you speak to the other individual, how do you come across, how do you behave, and how are you able to communicate in general in terms of discussing different ways in which how care can be provided. So communication is very important in this sector and is considered one of the key skills. So one of the C's in 6 C's of care is basically communication, because it is expected that the individuals working within this particular sector or in a particular healthcare setting will have high quality of communication. That means their communication skills would be would be very, very good. Now, when we talk about C for courage, we are looking at people being bold in this profession, that they are able to take decisions or difficult decisions. Sometimes when they face challenging tasks, they're able to make those decisions. They have the courage to be able to speak and provide say, for example, sometimes you have to give an adverse piece of news to the family member of the patient that this has happened, or this was the circumstance. Then they have the ability to be able to communicate that, but communicate that with courage, in the sense they have they muster the courage and the boldness to be able to speak up and essentially voice their concerns. So it could be concerns, it could be communicating conditions, or adverse decisions, or in some cases outcomes, not decisions, adverse outcomes in some cases when they are dealing with families and friends of the patient. So here you would be looking at trying out new approaches, you would be looking at taking up challenges, you would be looking at understanding how sometimes adverse news or decisions have to be communicated, and that is what requires you to have courage when you work within this sector as well. And the last C that we talk about is commitment. Now, the reason why commitment has been put here is that there are some government legislations and laws which are required to be adhered. That means there is no skipping those standards. So when we look at the basic laws and acts that have to be observed when you're working within this sector, things like access to data. You have access to patient data, but you cannot misutilize that data, and you're bound to understand what is data protection, what are user rights, and obviously who has access to that data. So if you're a manager and you have access to patient records, you would set user access rights. If they need to access the data, they will go through certain channels, permissions, requirements before that data is made available to them, because data, that patient-sensitive data in the wrong hands could lead to complications or situations wherein it could be put to malpractice or different use. And it is your responsibility to ensure that you understand the commitments which are required to be made when we look at implementing and enacting some of these acts and legislation. So things like data protection, things like equality and diversity, things like discrimination, Disability Act, things like making sure that you follow all the policies and procedures which are being laid down, and you have adequate knowledge of providing information. You're not providing or leading to misinformation being spread within the setup or the setting. And that is where commitment to giving your best, commitment to giving your 100% is required within this role, which creates positive experiences for patients, and they get the support and care which is required, because you're following the correct procedure and you're committed to following the correct procedure and processes which have been laid down while delivering service and support to the patients within a particular healthcare setting. So these 6 C's of care are important, and they are very important because they're related to person-centered care, which is personalized care being provided, but at the same time, you're adhering to making sure that the care being provided, when you provide that support and let's say the encouragement to the patient to get better or get well soon, you are also having these qualities of compassion, communication, courage, commitment, and competence to be able to deliver on that role. And that is where we will cover these 6 C's of quality care, care, 6 C's of essentially care, which are underpinning the person-centered approach in the National Health Service. Now, we will look at just the last criteria, which is basically the distinction criteria, talking about, what do we look at and mean by, essentially the importance of health and social care workers, and how you go about demonstrating that person-centered values are a part and parcel of your delivery when you perform your jobs and perform your role and responsibilities in a particular area. Now, here one of the key benefits that we've talked about in terms of PCA is that it helps to meet the emotional, social, and practical needs of the patient, so that the care being provided is tailored and is meeting the requirements of the patient. The patient feels confident, the patient feels protected, the patient does not feel vulnerable, and they feel that their needs and responsibilities or needs and wants are being taken into account while this care plan is being implemented or it is being provided by practitioners. The second bit that we look at is the person-centered approach, helps develop knowledge, skill, and confidence within healthcare workers as well, because it helps effectively manage data, information, which is then used to make decisions. And those decisions are made in the context of the patient for the benefit of the patient. And these decisions are, for example, if you are, let's put it this way, that if you are, we take that same example that Malcolm has had an accident, he has been hospitalized for a period of 2 weeks. Now, within the 2 weeks, because he's incapacitated, that means he cannot move about, and he's on the bed. The nutritional requirements or the food that the person needs to be served will have to be a balanced diet. Now, when we look at balanced diet being served, there will be certain bits which will be provided to the patient in his breakfast, lunch, and dinner, which would be giving energy and obviously requisite amount of calories which the person needs to intake, so that there is no loss of body mass. That means there is no loss of weight while the person is being hospitalized. And in those 2 weeks when the patient is on the bed and has very restricted or little movements because they've undergone a procedure or an operation. So in this case, when we talk about the importance of how person-centered care can be delivered to Malcolm by healthcare workers or healthcare assistant and nurses while he's in the general ward or maybe in the hospital during those 2 weeks, they would take into account the needs and wants of the individual to ensure that he's being served the food which meets his requirement. That means if he's a vegan or is a vegetarian or is allergic to certain food, then that food is, or that particular type of food is not included in the diet or the plan which is being provided to him as breakfast, lunch, and dinner. And that would be the importance of having, demonstrating essentially that you are taking into account the person-centered approach while providing treatment or taking care of that patient. Now, one of the questions which should come to your mind is that why is it important when we talk about person-centered approach, and why is it so central to everything that we discuss within the national service? And when we talk about treatments, when we talk about diagnosis, planning, care plan, why is it central to that particular approach? Now, it is central to the, in terms of as an approach, is because patients are more likely to stick to treatment plans and take their medications if they feel they are involved. Now, if you have somebody undergoing some treatment and they feel that they are not involved and their objections or their doubts have not been taken into account and have not been fully answered, you would generally see that patients don't interact and work with you towards, getting that treatment. And it becomes, in those cases, bit, let's say troublesome or tiresome for the people involved in providing that care. So it is always important that we have a buy-in from the customer. And then when I say buy-in from the customer, I mean buy-in from the patient who is well informed, is willing to come along and, go on with the team and, let's say reap the benefits of the plan when they have been explained the things in detail and they are able to make their decisions. So their patient's involvement in the delivery of plan is very important. The second bit that we look at is that because we look at, and we hear this in the news, that there are NHS is under strain, a lot of our resources are under strain, there are shortage of nurses, doctors, this and that. So in order to ensure that there is less wastage of energy, time, resources, and the patients are getting the due care and support that they are required, it is important for us to stick to a plan. And that plan is person-centered care, which allows less wastage of important resources to happen when we look at the National Health Service. It also motivates the patient. It also will look at helping to build a positive relationship with the patient while the care is being delivered. And because you're incorporating the 6 C's of care, compassion, you're looking at following things which are detailed out, primarily in terms of the care principles, then it has the involvement of the patient as well in terms of receiving that plan. And obviously, when we look at resources being spent, these resources tend to be, more cost effective and, less time consuming when we follow this particular approach, as far as the person-centered approach is used by healthcare workers in delivering that plan. Now, in the subsequent slides, what I've done is I've taken a particular example of how a traditional plan would work in some cases. And if a patient with mental health care, if the patient has some disabilities or is basically, having certain disabilities because of mental care, then in those cases, how a traditional care plan would differ and, will be made specifically bespoke to the person who's having, disabilities which are related to mental health care services. And that is an example that we need to be able to take, because this task talks about analysis of, basically the analysis of why person-centered approach is important in delivering, services and care to the patient. So here we need to be able to take an example of what is a traditional approach and what will be the PCA approach when a plan is put together, or a care plan is put together, or care or a support plan, as we say, is put together for a patient who is receiving mental health care support, from a particular setup. And that would basically be required to be taken to discuss in this particular task. And that is where I've taken a practical example of, discussing that a woman, say for example, M, she's 67 years old and she has, mild mental health illness. That means that she lacks the capacity to be able to take decisions. And also because she has some underlying health conditions, things like diabetes, she needs help in this case to be able to, do some daily course on a day-to-day basis. Now, when this particular case is brought across to the attention of the local authority essentially decides that the patient needs to move into a care home because, one, they live alone, second, they have underlying health conditions, and third, they suffer from mental health illnesses, and because of which they are not able to make decisions or do the daily bits that are required to be done. And that is where the patient needs support. So the local authority steps in and takes a decision that the person needs to be transferred to a care home. Now, in the care home, what has been observed is that the person is quite independent. She likes to, for example, do some of the daily chores and, herself, things like making the tea or dressing up. But the care room puts a bit of restriction on this aspect, wherein they provide support which the patient does not welcome. So in this case, what will happen is the care plan, which will be put together by healthcare workers for the particular person, would involve in understanding what the patient can do, cannot do, what the patient is willing to do, and what kind of support is utmost required to be provided. And they will put this plan into place by taking into account the person-centered approach, which is looking at individuality, looking at the basic bits of individuality, dignity, respect, independence, and then marry them with what functions can the patient do and in which places they would need help and support to be able to carry out those tasks. And that would help you do the analysis of why it is important for healthcare workers to follow person-centered approach while delivering support and care to patients within, say, a care room. So that brings us to the end of the discussion today, specifically for Learning Outcome 1, which talks about understanding person-centered care. This is quite a detailed learning outcome. Now, there are a few handouts which I have created, and they are the handouts which I would request everyone to go through. The bit on, there's a safeguarding guide from the NHS, which basically is quite a bit of reading. But essentially, I would suggest that if you read the CARE Act of 2014 in particular and the Mental Capacity Act of 2011, they would be quite useful for you to understand why safeguarding principles are incorporated in person-centered care. Now, this is a PDF document. You will be able to see this, and it covers some bit of safeguarding and the principles of safeguarding and principles of care, which is the 6 C's that we've talked about. And this particular document, the relevant parts of it, I have included in the presentation, should you wish to go through. And this part in the presentation is given here, which I did not in particular want to discuss because this is something that you can read. And this is one of the most important acts, the healthcare acts that you need to be aware of when we study, person-centered approach. So I've created a few slides which have come in from that particular handout, and it talks about the person-centered care in context of the Health and Social Care Act of 2014. And the 6 principles of care have been discussed on individual slides for you to go through. Now, the second handout, which I would want you to go through on Learning Outcome 1 in particular, is going to be looking at reading or doing some additional reading on the SCIE website. And I'll show you a link which talks about the safeguarding principles. And this is where I think it will give you some sense of what are the responsibilities which people need to have or they need to adhere to. And this particular link is given towards the slide which talks about further reading, which is slide 44. It's a 10-minute read on safeguarding, and I would suggest that everybody goes about reading this particular page on the SCIE website, which talks about the 6 principles of safeguarding, the responsibility. And I've referred to different types of abuses, things like modern slavery. We look at domestic abuse, physical abuse. So it basically talks about the different types where abuse can happen with patients or people, and why the safeguarding acts becomes important. And it is going to be something which will increase your knowledge about the aspect of task 1.3 in particular, which is mentioned related to safeguarding. Now, this is the article and the link which I put in the plenary towards the end, which says further reading on safeguarding. And if you go ahead and click on that article, it will take you to the SCI website, which is where you'll be able to read a bit more about the concepts of safeguarding. Now, last but not the least, I would want everyone to look at the care plan template, because this template in particular, which will be available on Moodle, gives you again a good idea in terms of how a care plan is put into place for a patient which is undergoing some sort of treatment within a hospital or within a particular setup or a healthcare setting. And this is just a template for you to familiarize yourself with, so that you're aware that this is how a care plan is put together, which takes into account the basic background of the patient, the allergies, the medical conditions, basic tests, and has the minimum set of information required for GPs, consultant, doctors, practitioners to be able to make decisions when a patient is brought in or is requiring additional treatment with regards to any condition or any fatality that they have had because of an accident or because of a disease or an illness. So these bits would help you greatly understand and comprehensively cover, I would say, the first learning outcome, which is understanding person-centered working. And I hope these 2 sessions have been useful. The presentation available on Moodle along with the handouts and the recording of the session on the YouTube channel, should you wish to revisit this again. Any questions at this stage? Now, one of the last things which I would also do, for those of you who haven't, and I'm going to share my screen fully because I just don't want to flip over between different screens. So you might see a bigger screen. Now, for those of you who haven't done the task 1.1, which is a Word document called Person-Centered Values in Practice, you have to go ahead and fill this document up, because this will become a part and parcel of your task 1.1 in the assignment. There is an additional handout which is available on Moodle, and that is person-centered approach. This has been downloaded from the Health Foundation, and it talks about person-centered care, the history which I referred to or related to, that the American psychologist Carl Rogers came up with this approach. Then it was presented to the American Medical Association, and then finally introduced as putting people first in the UK in 2007, and then incorporated into the National Health Service Act of 2010, and how this approach has become the central approach of everything in terms of every service which is provided. When I say service, I mean care or support which is provided to patients receiving treatment within any sort of a healthcare setting in the NHS. So how this whole concept of PCA came about started with Carl Rogers in the 60s, late 70s. Then some white papers were published in the American Medical Journal. It got adopted in the US. Then it came into the UK in 2000. There was a white paper published by Lord Darzai. It was then published in 2007 along with the People's Putting First approach. Then at a later stage, it got incorporated into the NHS Act in 2010. And then later on, this approach has now been centralized into the Health and Social Care Act of 2014 and is now followed as an approach across the National Health Service in the UK. So this is a good 15-minute read, this particular document, and puts a lot of information that some of you would want to read and go about and find. And that would be a concise reading document about person-centered approach. And this is also available on Moodle. So we'll be meeting next week now to discuss Learning Outcome 2. Learning Outcome 2 is going to be focused on, discussing effective ways of communication in health and social care. Some part of this we have covered in the communications unit, but we will be discussing this in a more broadly in more detail, because as you can see, there are a number of assessment criteria, and we would want to revisit some of them to ensure that there is a comprehensive coverage, on this side. So up until then, I would suggest go ahead and read some of these documents, go through them in detail, and then submit this particular bit, which is the person-centered approach bit, which I mentioned to you, so that this will be looking at meeting some of the criteria, for your assignment for this particular unit. Thank you so much for attending. If you have any questions, feel free to drop me those questions and the document that you complete on Learner Work, and I will catch up with you next week to discuss Learning Outcome 2.
Thank you so much.
Thank you.
Thank you.
Thank you, everyone. Bye for now.